Welcome. My name is Danish Bhatti. I'm an assistant professor in the Department of Neurological Sciences at University of Nebraska Medical Center. And I have the pleasure of having Professor John Bertoni, MD, PhD, the Director for Parkinson's Disease Program, with us today to discuss an important topic about nutrition and Parkinson's disease. John, do you want to say anything?
Well, yes, we are co-directors of the Parkinson's Disease Clinic now. So it's a pleasure working with you, and as you know, we're into some important research about nutrition in Parkinson's disease.
That's right. So I have trained with you as a mover disorder fellow, and now been working with you for the last 5 years. I know that you've always paid attention to nutritional status and vitamins of your patients with Parkinson's disease. And I've seen your patients do very well with their Parkinson's disease for 20 years, 30 years, and they're still walking to your clinic and coming regularly. And I've always tried to figure out what are those things that I can replicate and have my patients have similar outcome. So I am now working with you, and we're working together on this nutritional study of Parkinson's disease. Why don't you tell us a little bit about what is this study?
This study looks specifically at the vitamin levels at patients, in our patients with Parkinson's disease. We are working with folks at Harvard. There's a friend of mine, Walt Willett, that works in the School of Public Health that's developed a Harvard Food Preference Questionnaire. And as you know, people with Parkinson's disease have loss of olfaction, sometimes very early, and they tend to choose the wrong foods. We're trying to specifically find what is it about their diets that's different, what are their needs that are different from ordinary people, and how we can solve those problems.
So since when have you known Walt Willett?
Actually, we go back to medical school days. He was a year my senior at University of Michigan Medical Center, and I've kept up with him and found out what he's been doing from time to time. And he's developed a fantastic worldwide, translated into many different languages, food preference questionnaire. There are people that suffer from wet beriberi and other conditions that are basically because of their diet.
How did you find this food questionnaire to work with in Parkinson's patients?
Actually, I contacted Walt, and we talked about it, and he suggested that we use the questionnaire.
So you knew Walt was doing some work in nutrition?
That's correct. And I can't remember exactly what the first step was, but what happened was we had phone conferences, and now we have decided, and now we're embarking on a study that's IRB approved here at UNMC.
So the study is looking at the dietary habits of Parkinson's patients as they present to our clinic.
Yes.
And we're measuring their vitamin levels, the nutritional vitamins that are commonly low.
Yes.
Namely vitamin B1 or thiamine, B6 or pyridoxine, B12 or cyanocobalamin, and vitamin D.
That's correct.
And what do you want to find out about this diet and correlation with Parkinson's?
Well, first of all, we want to find out on a group of patients that present in our comprehensive clinic. These are usually new to us, but sometimes these are patients that we've also found out may have a nutritional problem. So everyone has to sign a consent form and is given a questionnaire that takes
So do
several
you think
minutes.
that vitamin deficiencies may have something to do with the kind of food they take?
Yes, yes, because for example, we go for the foods that we enjoy because of the aromas, more than I think the sweetness, sour, bitter, and the Japanese also salty and
Umami.
pungent. Yes, right. So we're looking to see why patients eat differently with Parkinson's, why they have a vitamin deficiency. So we found low vitamin B1, which is really hard to be low in vitamin B1.
Because it's so prevalent in
It's in
many kind of
everything.
foods.
It's
Yeah.
in healthy foods.
Yeah.
but I just saw a woman in the emergency department a couple nights ago and asked her what she was eating. She has Parkinson's disease. She says for breakfast, I'll have half of a Diet Coke and one slice of white bread. And then she went on, and the diet was like that. I mean, she had a cheese sandwich in there somewhere, but basically just
no greens, no vegetables, no fruits.
No, none.
So no vitamins.
No, none.
So you think that the vitamin deficiencies is common in Parkinson's. It is likely linked to the dietary habit of Parkinson's patient, which is probably due to changes of Parkinson's disease in the brain?
It has many causes. The causes include that they lose their appetite with the medications we give them. They lose their appetite because they have constipation and their food travels slowly through their GI tract. They have less of an appetite. They don't burn as many calories and they don't need as much, according to them. But as long as we give them the right vitamins and find out what they're deficient in, one of the major reasons is how do we predict? I mean, there are over 200,000 people in the United States that are thiamine deficient.
Wow.
Now, as a fraction of the total, that's not a very big part. But we want to know, what is it? Is it that they have weight loss? Is that the key? That we should ask the people who have lost more than 5 pounds and do these studies? That may be one of the outcomes we find. Another one might be that we should screen everybody at the beginning. People that have neuropathies, you know, many of these vitamin deficiencies cause neuropathies.
Like a nerve damage.
Right, like a B12 deficiency, which is really not too rare in the elderly. They lose their ability to absorb B12. So with all of these things as
you think that vitamins are deficient for possibly various factors, including the slowness of the bowel movements, the delayed gastric emptying,
yes,
the medications making them nauseous,
yes,
with poor appetite, loss of sense of smell with not having much aromas to go by and feel appealing. And then Dr. Ron Pfeiffer's work showing small bacterial growth in small bowels.
Yes.
If I think of one more thing, is that some of these medications can actually reduce vitamin absorption, such as carbidopa can block vitamin B6 absorption.
That's correct.
And now with the Cinnamon infusion pumps, the carbidopa levodopa infusion gel, we're finding a lot more B6 and B12 deficiency. That's very interesting. So you think that vitamin deficiency is being caused by all these factors related to Parkinson's, but is it in turn affecting their Parkinson's disease in any way?
You know, it really does affect, because when you look, it does affect their illness, because when you see what the risk factors are, if they get osteoporosis from lack of vitamin D and lack of calcium in their diet, they don't eat much dairy products, and some of them can't really digest dairy products very well at that age. If they don't take in enough protein, they're going to have weaker muscles, and they're going to tend to get a neuropathy, and they're going to tend to fall more easily. And when they fall, they're more likely to have a fracture. So these things will then put people in the hospital, and in the hospital they're given so many medications. There's medications to wake them up in the morning, and medications to put them to sleep at night, and medications to calm them down, which may make the problems worse.
Do you think, one other thing that comes obviously to mind is some vitamin deficiencies can cause problem with balance, poor balance and postural instability and increased risk of fall, combined with the weak bones or osteoporosis that you mentioned. But do you think Parkinson's disease progress differently in people who have a good diet or bad diet due to nutrition or other factors of vitamins?
You know, I have hunches, but that's why we do studies.
Right.
I do think that the choice of the foods that you eat every day make a big difference in how tough, how strong, how capable you're going to be, mentally and physically. And if you eat right, and if people find you get a vitamin deficiency and get it replaced, you're much better off. You only have 2 hips, and if you break one of them, you're bedridden, and some people don't get out of nursing homes. They end up ending their life there. So this is an important thing. Yes, I do think that we can intervene. The real question is, who are the people most likely to suffer from vitamin deficiencies? How do we recognize them? And how do we make sure that their quality of life is optimal?
It's interesting. We have discussed about some of the literature that came out in the last couple of years, and we've shared articles with each other. We have seen reports that in a large community, if you look at vitamin D level on Parkinson's patients, the ones with low vitamin D level seems to have a faster progressed Parkinson's or a worse off Parkinson's disease. We have also seen similar reports about vitamin B12, and I sent you a paper where in a mice model they gave very high doses of vitamin B12,
Right.
one form, active form of B12, which has 4 active forms, and it showed that they were more resistant to developing Parkinson's disease, like damage in their brain from
Right.
the chemicals we use to create Parkinson's hormones in mice. So that was very interesting, and then we have seen similar reports for thiamine. So it sounds like there may be some support now for your hunch about vitamin deficiencies being important for Parkinson's disease. So if you want to say anything more about that, and do you think there are more things beyond vitamin deficiencies about diet and Parkinson's?
Well, we have vitamins alphabetically, and there are many B vitamins.
Yeah.
But if we think we have found all the vitamins, all the essential nutrients, we're fooling ourselves, because there are more and more. Iron, for example, is often low in people with a very, very poor diet. And if they have GI distress, then that's another reason for them to become weak. So I don't think we're done discovering nutrients. We need to find out what are the causes of the low nutrients, and we need to fix it. And yes, there are GI, we're outnumbered 100 to 1. What we have inside our GI tract.
You mean the bacteria, the germs?
Bacteria, if you count every one of those bacteria, and every cell in our body, all our muscles, all our brain cells, nerve cells, everything, we're outnumbered 100 to 1. So we don't want to be a democracy. So we have to make sure, and some of these organisms actually take out the important ingredients in Cinemet or carbidopa-levodopa.
Right.
They minimize the effectiveness of the medications we give. Some of them also make it difficult for B12 to be absorbed. So there's many, many different interplays between what we eat and what it does.
That's true. It's about constipation and bowel movement, and we know if there is slow gastric emptying that can affect the absorption of medicines that the patients take and make the response to medication less predictable, more erratic. So gut seems to be a very important center in management of Parkinson's disease, and might even be in progression of Parkinson's disease. What do you think about these ideas that it may also have a center role in onset of Parkinson's disease or beginning?
Well, like you said, Ron Pfeiffer, who is one of the big leaders in the Parkinson's study group, and one of his things is to look at the GI tract and what is going on with that as a cause of Parkinson's. Because sometimes bacteria can get in, or other particles can get into our bloodstream and into our bodies, into our brains. And there is a hypothesis, as you know, that there's a nerve that controls the GI tract called the vagus nerve. It means wandering nerve because it's so long. And when that becomes affected, it affects the brain stem, just above the spinal cord, before the brain that we think with. And then it progressively moves up to the pons and to the midbrain. And in the midbrain, it causes Parkinson's disease. That's where Parkinson's disease can start. And then the olfaction is lost in the early process. And then if it progresses into the entire brain, then we have a dementia, a Lewy body dementia, which is a form of Parkinson's disease. But, you know, some examples I can tell you about are remarkable. You would think that physicians, of all people, would not get into vitamin deficiencies. And as we talked about before, we have 3 or 4 cases of physicians and nurse practitioners that have Parkinson's disease that have come into our comprehensive clinic, and we're amazed how low their vitamin B1s are.
So tell me about a specific case. Let's focus on a patient, how it can affect their life. So
Well,
tell me about a case where you are really impressed by the importance of nutrition and vitamin deficiencies in Parkinson's.
my neighbor, years ago, behind in our backyard, was a retired physician. And I noticed he had a very mild form of what we had to call Parkinsonism.
Mm-hmm.
We didn't see much in the way of tremor, but there was a slowness, but a lot of older people get slower. So I was just watching him in the clinic and not making a firm diagnosis, and he was interested, but I think he knew he was getting Parkinson's. He was a smart enough guy. So eventually, he would come to our symposia, where we had hundreds, and lately about 1,000 people coming to learn the latest about how you get Parkinson's disease and what you do about it.
Uh-huh.
And then it became clear this really was Parkinson's disease.
In that patient?
In that patient.
Okay.
So he started to have a tremor, he was bradykinetic, he had all the features, and we started to record things. I checked his vitamin levels, and he needed vitamin B12.
Okay.
So I finally convinced him, you know, physicians can be difficult patients. Let's admit it. So, because we think we know we do know too much, and sometimes that gets in the way. So anyway, I said you have to take B12 shots. Then the time came when he missed an appointment.
Okay, so he was coming regularly.
Coming regularly.
This is your old neighbor physician.
That's right. So the last visit, I checked his cognition, and he was slipping. And I said, we need to do some testing to see what things you're good at, what things, we call them neuropsych tests.
Right.
He refused. So next thing I knew, I went to see my eye doctor, and he asked me, do you know Dr. So-and-so? We're not going to...
This is after a gap of certain time since you've last seen him?
Right, because he didn't come. He didn't. So finally he said, do you know him? And I said, yes, yes.
Your
Yes.
ophthalmologist?
Yes, my ophthalmologist said, was also his.
Was his ophthalmologist?
Yes.
Okay.
So
a common doctor?
A common doctor. And he said, do you know Dr. So-and-so? I said, yes, yes. He was my neighbor, and a really good guy. Why do you ask? And he said, he's not doing very well. So I finally got him on the phone, and I said, you must come in.
Your older neighbor?
Yes.
Older
Yes, so I had to lean on him a little bit.
Okay.
So, and his wife tried to get him to come in, and he sometimes would, sometimes wouldn't. But the situation is, we're going to take a break.
So this was after a gap of how much time?
It might have been a year and a half perhaps.
Okay.
Okay, so what I did was I had him come in, and I said, we're going to test your vitamins.
Okay.
And his vitamin B12 was really low.
How was he when he came back after that year and a half of a gap?
His mini-mental status had deteriorated even further.
So he was worse cognitively?
Worse cognitively.
And physically?
Physically, he was quite a bit worse. And we do a score, we put him through the tests, and you know...
Was he taking any medications by then? Were you prescribing anything?
Not taking them regularly. So
okay.
He was a typical, I think he just was forgetful more, and who knows, but maybe he doubted that he really needed it. Or maybe he felt like he was not
Or maybe he was
enough.
forgetting to take them,
I think,
because he was having cognitive challenge.
So I found that he was not, if you have to have 180 or 200 as a level
bottom
line, minimum, and even at 250 we tell people to take more B12.
Right.
His number was 72.
Wow.
And I called him up and I said, you're taking shots, right? He says, oh no, I quit taking those.
He was on B12 shots because you earlier found him on a mild deficiency
and recommended
B12 injections.
Because he wasn't getting enough or wasn't taking the vitamin
And at
B12.
72, that in itself can cause dementia. It's such a
And
low
can-
B12 level.
Yes, it can. And so it feeds on itself. If you're not remembering to take it, then you're going to get more and more dementia. So this is what happens to people. In the thiamine level, it's very hard to get low in thiamine. There are some conditions where, some situations like congestive heart failure, some of those patients really do have a vitamin deficiency, and it may be thiamine. So anyway, his vitamin B1 was extremely low, so was the B6, and his vitamin D3 was low.
So almost every vitamin was low that
Everything
you
we checked, yes.
Was he losing weight? Was he eating?
He was losing weight, he was not eating, he was now using a walker. And it's interesting, his wife was honestly getting burned out because he would just not listen, not do, and part of that I think was the dementia itself. So there's an example of, number one, somebody who should know better.
Right.
But you know, we have what's called the human condition. Even if we know we should do something, we don't always do it.
Right.
And so I got him back on all these medications, and he was back in the normal range.
This is very, this is clearly a dramatic example, but a very clear example highlighting how nutrition can adversely affect you, much more so than just the disease itself, just the Parkinson's itself.
Right.
And maybe your Parkinson gets worse or your cognition gets worse. So, it's interesting that we check vitamins, these nutritional vitamins, routinely
Right.
in our patients. And I was a little surprised a few days ago when we met this professor visiting from California, who said he does not check vitamins on his patients at all unless he see a clinical sign of a deficiency, which we know are so vague and so hard to pick. And we find on routine screening very often vitamin deficiency. So it makes me wonder, I have a couple of questions. One, what makes you convinced that it's a good practice, clinical practice, to check these vitamins? It's not a guideline or recommendation from anywhere. And two, how often do you find these vitamin deficiencies? And did that made you be more convinced that you should do it more often?
That's a really good question. It goes back to a patient that we have discussed before that had a short gut syndrome.
Uh-huh.
And she was labeled a spinocerebellar degeneration. I couldn't figure out which one. I studied them.
That's way back we're talking
Way
about.
back. This
when
is
you
in
were
my
a resident. Your first
Yes.
year neurology resident.
And everybody told me there was nothing wrong, it was clear, and I said, there's nobody in the family that has this. A lot of these are familial. And I said, so we worked with, I just decided to do a lot of studies. She was deficient because of no small bowel that had to be taken out when she was an infant, that she couldn't absorb any fat-soluble vitamins.
I see.
So, and she was also, her B12 was normal, but her vitamin A, vitamin D, vitamin E, and vitamin K were all the fat-soluble vitamins. So this was the first adult case, and she developed a problem like during her high school graduation, and I saw her in her 30s, and we solved these problems, and her visual acuity got better. Her vision, she had a narrow field of vision, and we showed that it did expand with treatment, which is, so that was very...
very early on,
very early
you
on.
got an evidence that vitamins are important and nutrition plays a big role in neurological disorder.
Right.
With Parkinson's, when did you start getting that similar hunch or ideas that
I
vitamins
think
are important?
I have been having a high index of suspicion for this. When somebody comes in with a neuropathy, and you know me, I check neuropathy on everybody, and when somebody has more difficulty with gait or has a fall, I check them again. And if there's any doubt, I have an EMG done, we identify what the cause is and solve it. So a lot of times, it's things like diabetes that can cause a neuropathy. But if we don't manage the diabetes, and the patient also has Parkinson's disease, they're going to fall, they're going to break a hip, they're going to be bedridden, their quality of life is going to go down the
So
drain.
now, when you do routine vitamin levels, B1,
Right.
B12,
Yep.
D, how often do you find them low without any clinical evidence
You
of
know,
deficiency?
that's part of the reason we're doing the study, because I remember the ones that are really, really low, and that I feel so glad that we checked, because we probably prevented major.
If you have to make a guess here, 5%, 10%?
I'm thinking it's more like
20%?
10%, and in my reading, you wonder, there are people that are now saying there is a connection with B12 deficiency. Some people say vitamin D. Of course, we get a lot of vitamin D from the sun, and where we are, the sun is low a lot of the year, and we don't go outside because we can get cancer. We can get melanoma from being out in the sun with Parkinson's. So we have to get the right amount. So I would say about 10%, if we include iron deficiency. I have found people with severe iron deficiency, and it's good to pick that up also, because sometimes there's a very early GI kind of neoplasm that if it's small, just starting, you can get all of it into the bucket, as we say, by an operation or even a biopsy on a colonoscopy.
Well, just to complete the list, the other one that I often do, and I think we both do in balance problem, is zinc level. And I actually find a lot of zinc deficiencies,
Yes.
which is not supposed to be very common, but surprisingly in our patient population they are. And so I want to circle back where we started. Where are we now with the Howard Food Questionnaire and Nutritional Study in Parkinson's? And how many patients you have, what kind of data you have, and what are your next steps with the study?
Well, I have reviewed the most remarkable cases, and we're beginning to write case reports now. There are 3 or 4 such patients that are illustrative of why we need to check. We now have, with the Harvard Food Questionnaire, I believe, about 150 people that have volunteered to be in the study.
Okay.
And what they do is they take a one-time questionnaire, we analyze their vitamins and nutrition, and we correct it. As you know, in our comprehensive clinic, we have occupational and physical therapy, speech therapy, and swallowing at the same time. We have a nutritionist, we have a social worker. We do the whole thing.
And a nurse case manager.
Nurse case
for
manager,
education.
which is, she's the point person
Right.
of our whole system. So
you're
we have
doing it
150.
for...
We're going to go to 200, and we've already had one of the master's students that our nutritionist is working with collect the early samples, but I don't think we have all the results of the food questionnaires yet.
Okay.
I think they're doing those
The
in
food
batches.
questions would be analyzed, and then we will correlate it with the Parkinson's disease in terms
Yes.
of severity and,
Right.
and presentation.
Right, because I think we're going to find that they go for the salty and the sweet foods and not the nutritious foods.
I see.
But that's why we do a study, because it's a hunch until we prove it.
Wonderful. That was great.